thank you for joining us for our first abstract session at this meeting this afternoon. And before we dive right into sharing the work that people do, just a few housekeeping issues. Number one, again, thank you for being here. This is, with everything that's been coming through for the last 2 years, it's a great step and a big step, and it's a good step in the right direction. Please join us at the exhibition hall during breaks and at the end of the meeting to talk, get to know each other, clarify, ask questions, debate, and thank the exhibitors. Tomorrow at 7, we have an educational breakfast session. So please stop by and check that out. And then there's time and room still to sign up for the hands-on ultrasound block workshop that's taking place tomorrow afternoon if you're interested. CME credits, you will get an email after the meeting next week where you can download your certificate. And last but not least, societies live through their members. So if you're not a member yet, please check out the society at ARS USA and sign up online. It's easy. And you get great perks and support the mission of improving perioperative outcomes in the US. And that, with no further ado, our first abstract session.
All right, guys. Well, good afternoon. My name is Andrew Franklin from Vanderbilt University. I have the honor of moderating this first abstract session with my colleague, Dr. Jankowski. And so the format of this is it'll be a 5-minute presentation per abstract individual, and we are going to do it kind of like a elevator pitch style presentation where after 5 minutes there will be a little timer that goes off and they'll get a little beep. This is a competition, and so the people are competing for fabulous cash and prizes. Dr. Scott has graciously accepted by purchasing a brand new Tesla for whoever wins this. So, and I believe there's also a plaque involved, and so thank you for Dr. Scott for buying that brand new Tesla. So we're going to go ahead and get started. We're going to start with our first 3 panelists, our abstract presenters, and then after you hear that ding, you can have a seat, and we'll move on to the next one. After the first 3 abstracts are done, there'll be a 5-minute Q&A session for everyone in the audience. So first up.
All right, so my name is Brenton French. I'm a 3rd-year surgery resident, or general surgery resident at Virginia Commonwealth University in Richmond, Virginia. And I'm presenting our study titled Goal-Directed Hemodynamic Optimization to Reduce Acute Kidney Injury Within an Enhanced Recovery Pathway for Colorectal Surgery. So I have no interest to disclose for this talk. So postoperative AKI is a common occurrence, and it has a known association with adverse outcomes in surgical patients. So interventions to reduce AKI are needed. And goal-directed hemodynamic therapy is defined as the use of cardiac output monitoring to guide the administration of fluid and vasopressors during surgery. And intraoperative GDHT has shown the ability to reduce complications, including AKI, in surgical patients. So the aim of this study was to evaluate the effect of a quality improvement program designed to reduce the incidence of postoperative AKI in patients undergoing major elective colorectal surgery at our institution. So at VCU, we essentially designed and implemented our own GDHT algorithm to use during surgery, and we incorporated it into an existing ERAS pathway for major colorectal patients. So what we did is we reviewed the results of our GDHT QI program in kind of a before and after analysis. So our program was begun in September of 2019, and we compared GDHT patients to historical controls from the year prior to the program implementation. So we evaluated consecutive adult patients undergoing major colorectal surgery. So this is open or laparoscopic major abdominal surgeries. Our primary outcome was AKI incidence, with secondary outcomes being cost of hospital stay, the length of the postoperative hospital stay, and time to postoperative return of bowel function. So our exclusion criteria, we excluded any patients with a length of stay of less than 1 day, mainly to exclude more minor procedures. Anorectal procedures were excluded, non-elective cases, and comorbidities of dialysis dependence, pulmonary hypertension, or moderate to severe ventricular dysfunction, as these patients were not included in our QI program protocol. And AKI was defined by the Kidney Disease Improving Global Outcomes definition, so a stage 1 AKI is a 0.3 milligram per deciliter increase in your creatinine, or 50% from baseline, whichever is less. So for the specifics of our intraoperative GDHT plan, we use non-invasive cardiac output monitoring with either bioreactance, esophageal Doppler, or arterial waveform analysis. Choice of device left at the discretion of the provider. However, most of these patients ended up using bioreactance. And at the start of the case, we did a volume challenge, either by passive leg raise, a Trendelenburg maneuver, or a 250 cc fluid bolus. So what this does was it gives you a target stroke volume for the case, and so if the patient during surgery dropped 10% below that target, a fluid bolus would be given with no additional fluid if the stroke volume didn't respond at least 10%. So this figure is basically a sample from our intraoperative protocol in the OR. We did give maintenance fluid at maintenance rates, and all fluid was balanced crystalloid lactated ringers pretty much. So again, the point of this was to identify and maintain a target stroke volume all during surgery. So at the end of the case, we did a final fluid challenge, and importantly, we mandated that all providers keep the mean arterial pressure greater than 65. And of course, to make this practical, the remainder of care was left at the discretion of the anesthesiologist. So in our results, we compared 162 historical controls to 159 patients undergoing surgery following GDHT implementation. And patients were included if they were not fully compliant with the protocol, but compliance with this reached 81%. So no significant patient or procedure factors were identified between the groups, with the exception of slightly higher COPD prevalence in our historical controls. Median fluid balance on post-op day 1 was similar between the two groups. Only the intraoperative fluid GDHT patients basically got an average of 350 cc's more fluid during surgery, was the only significant difference in fluid management. So, regarding the primary outcome, postoperative AKI following implementation of this, the incidence rate fell from 15.4 to 7%. So this is a 55% reduction in postoperative AKI. However, we failed to identify any differences in length of stay, costs, or time to return to bowel function. But again, we were not powered for these results. So what we did do as well was we did perform a multivariable analysis to basically remove the effect of any confounders. And on our adjusted analysis, we saw that undergoing surgery following GDHT implementation was independently associated with a reduced rate of AKI with an odds ratio of 0.28. And in conclusion, our GDHT program was able to reduce it by AKI by 55%, so we hope this can serve as a similar framework for other institutions hoping to reduce rates of postoperative AKI. And thank you very much for the invitation to present.
Thank you for that great speech here. It looks like we got our competition cut out for that Tesla. So we actually did our second and third presentation together because it's based off of the same project. So we're just going to be kind of pinging back and forth with our next two topics. So my name is Kathy. I am a surgery resident at Tulane, just right down the road, 3 minutes away. And my topic is about change of laboratory markers on malnutrition, frailty measurement in cancer patient enrolled in prehabilitation program.
I'm Marissa Doran. I'm a fourth-year medical student at the University of Queensland in Australia, as well as Ochsner Clinical School here in New Orleans. I'll be talking about cancer patient assessment in a preoperative prehabilitation program, self-reported patient outcomes and laboratory markers versus physical markers of malnutrition and frailty.
And before I start, I just want to have a special mention to Dr. Trouter over there. She is our lovely DNP who made this whole program happen. All right, and we have no disclosure, and here's a rough flow of our presentation today. So prehabilitation is a program that is designed to enhance the strength and functional status of a person in order to withstand a stressful event like surgery. Initially, prehabilitation only consisted of exercise alone to improve functional outcome. but it has now expanded to include multimodal holistic approach to counteract the muscle loss that is common in sedentary and ill patients, such as our cancer patient population. In addition to traditional measures of success, such as shorter length of stay, we also focus on patients' concern about their ability to function in the world around them, such as to walk, shower, eat, perform other daily routines, and interact with others, and return to their previous roles.
So why do we need prehabilitation? First, I'd like to talk about a study that consisted of 372 patients, 60 years and older, who underwent elective abdominal surgery. Those listed here. Graphs on the left show the percentage of patients who are still dependent on these activities of daily living over a 6-month period. As you can see, at 6 weeks, 22% of patients still cannot bathe themselves, and over 50% are unable to do their own housework, shopping, or laundry. They also found that fewer than 50% of patients had recovered to baseline physical performance levels after 6 months. The graphs on the bottom show that patients who underwent Whipple procedures had the slowest recovery. But what's the impact of prehabilitation? Another study published in Nutrition demonstrated that preoperative nutrition alone can lower the complication rates for elective abdominal surgery. Furthermore, this is one of our patients' direct feedback on the impact of prehabilitation on his life.
So the most obvious conclusion is probably to start prehabilitation. However, there are many research out there with inconsistent prehabilitation programs. In addition, in the American Society of Enhanced Recovery and Preoperative Quality Initiative, they published a joint consensus in anesthesia and analgesia in 2018 that demonstrated although 2 out of 3 patients who undergo major GI surgeries are malnourished and 5 times more likely to die, and the hospital can save $52 for every dollar spent on nutrition, only 1 out of 5 hospitals have nutrition screening process, and 1 out of 5 patients actually receive any preoperative nutritional support.
There are obviously many gaps to fill. With inconsistent prehabilitation programs, multi-centered study and meta-analysis is very difficult. Not every program out there is studying the efficacy of their program. We don't know which parameters can predict prehabilitation success, who would benefit the most from the program, who should be referred, and who's too sick for surgery regardless of prehab. The unknown role of patient compliance is also not studied.
So to bridge this gap and to optimize our upper GI cancer patient population surgical outcomes, we built this evolving prehab program in 2018. That's to think of Dr. Trouter. We gave our patients a starter kit that looks like this. A protein powder to build their muscle mass, vitamin D and omega to decrease inflammation, Creon if they're a pancreatic patient with pancreatic insufficiency. We give them a Fitbit to track their activities and give them inspiratory muscle trainer and diaphragmatic breathing exercises to prevent post-op lung complications. And to better study the patient outcomes, we also collected these measurements along with the patient demographics, their surgical outcomes, and compiled them all into our REDCap database. And we also focused on patient-reported data on their own health. These questionnaires, this questionnaire on the left is a PROMIS score that consists of the mental and physical score, and then the graph on the right consists of the PHQ-2 depression screening scale. And if they do screen positive for that, we also then expand to PHQ-9.
Here's a breakdown of our patients by cancer organ type. A majority of the patients included were either esophageal or pancreatic cancer patients. And on the right, you'll see a breakdown of our demographics. Of note, the daily walking compliance is just below 50%. Of note, daily walking compliance is just below 50%, but compliance to protein and supplements is much higher. This could be beneficial for our data analysis, as we have a group to compare to the 2 cohorts based on their compliance to walking. However, our ultimate goal would be to improve compliance in our patient population. Hopefully, with the Fitbit activity tracker, we will encourage them to be more active.
So for my part of this presentation, we looked at essentially two big questions. The primary outcome is to determine the change in laboratory values and functional measurement between the initial consult and the prehabilitation, the last visit just before surgery. And the secondary outcome looked at the correlations of those changes with their demographics, initial lab values, initial functional measurement, and also the ultimate program compliance. So here is a little flow chart. We started with 107 patients, and we excluded 37 because they did not go through prehab or lost to follow-up. And ultimately, we had 69 patients with these breakdowns for each category. And on the top here, you can see we have a significant improvement in albumin, right grip strength, frailty score, and TUG, timed up and go test. And the second part of this table here shows that average right grip strength in those who are compliant with their daily steps increased by 4.02 kilogram, and the non-compliant group decreased by 3.59 kilogram. And the frailty score for both cohort actually decreased. However, the compliant group decreased by a whole number. And lastly, we have these correlation changes in these heat map shown right here. And most of these findings are kind of intuitive, such as more significant increase in albumin is correlated with a low initial albumin. However, the correlation between the more significant decrease in frailty score and a low initial hemoglobin is a little less intuitive and warrants further investigation to assess the effect of hemoglobin on overall frailty score. So in conclusion, there is significant improvement in nutritional and functional status of patient after prehabilitation. Despite multiple variabilities, a consistent prehab program may significantly affect patients' nutritional and functional status. These changes are correlated with several initial markers which can serve as potential predictors of a patient's success in the program and aiding the selection of the patients for their providers to refer to prehab. Lastly, patients who are adherent to walking may develop stronger functional status at the end of the program.
I'll now talk about my portion of the project. And my main research question was, is there a relationship between patient-reported physical and mental status with their functional and laboratory assessment? This was taken at their initial visit when they were enrolled. You can see the functional measures we recorded as well as the lab values there. Here's my flow chart, and basically patients were excluded if they didn't qualify for rehab or they didn't complete the PROMIS or the PHQ-2. And then below is the values for each. So here's a heat map of the results that I found. Any of the other lab values not featured were not significant, but in the left table you can see that there's significance with hemoglobin, frailty, grip strength, both right and left, as well as ECOG score. And the ECOG score wasn't necessarily surprising for us, but we think just brought some validity to these relationships. And then the heat map on the right, you can see in the PROMIS mental score column a significant relationship with each value for the laboratory values as well as their functional and frailty scores, but there was no relationship demonstrated with the depression score that we measured. So as far as our conclusions from this, we found that hemoglobin and ECOG had a correlation with the functional measurements, and perhaps this illustrates that anemia is present in this population and that there could be some benefit to addressing this, or that this is poorly addressed already in this population of patients. Also, with the relationship of mental health, but not necessarily depression, we're wondering if there's something else going on, whether it's anxiety related or, as previous speakers had talked about, if there's some kind of cognitive function that's present. And if there's even something with this that we can improve upon. So like any research studies, there are limitations to ours. We had a small sample size, perhaps some less consistent reporting at the beginning when we were developing the program, and also some mixed stages as far as neoadjuvant chemoradiation and therapy at initial enrollment, and different types of cancers.
Okay, and as we took this project from database creation, clinic flow optimization, trained all the clinic staff, all the way to this presentation today, we came up with a few more questions to address. Does our prehabilitation program improve post-operative outcome and mortality? which of the measurements are most important predictors of the surgical outcome, and what is the optimal cutoff for each of those measures to achieve the best post-op outcome. So these are all the questions that we're actively thinking about, and we're going to invest in upcoming projects. So using the data from a self-reported patient outcome study, we decided to add a GAD-7 score and consistently also did a mini mental exam as well to assess the relationship between anxiety and cognitive function and frailty. And this project is based on patient data from 2018 to 2020. And we launched the HOPE-2 data officially in February 15th of 2021, and that's going to be the prospective part of our study, and these data also served as a power analysis tool for that study. And here are references. Thank you very much.
Thank you for, Matt? Yeah. Thank you for very good presentations. We'll take 5 minutes now to ask questions of our presenters. We'll start off with questions from the audience if anybody has them.
I have a question for the first presenter for the fluid paper. So what do you think is going on there? Is it because you give 350 cc's more fluid, or is it the blood pressure?
I think it's, so when you look at the two groups, so one group basically had no cardiac output monitoring, the second group did. The fluid amounts are similar between the two groups, but there's evidence out there that suggests even like 1 to 5 minutes of transient organ hypoperfusion can lead to a worse outcome or increase your risk of AKI or myocardial injury after surgery. So I think what's happening is the cardiac output monitors are kind of picking up when there's a drop in stroke volume or cardiac output, and they're picking up that like the patient maybe needs some additional volume at that point in time, depending on what's going on during surgery. I mean, it could be during, laparoscopic insufflation. It could be during, maybe there's an episode of major bleeding. And I think you're preventing those more kind of transient periods of hypoperfusion that lead to these better outcomes, is my theory. It's kind of hard for me to tell exactly, but yeah.
Yeah, I think the problem here is with using a historic comparison group to make sure that you don't have two things that you're changing, right? So I don't know whether you went through the record to see how their blood pressure was managed historically, whether it was the same.
Similar between the two groups, yeah, I can say. It's in like my appendix basically, but it's similar. It's just because the records were a bit older, the blood pressure isn't taken as frequently and saved into the system quite as often. So we have like Q1 to 5 minute vitals in the most recent patients, but if you look back like a year or so, it's only every like 5 or 10 minutes, so it's not as good, but from what I could tell, there were no major differences.
Yeah,
so.
thank you.
Hi there. My question is, why do you think everybody went to the NICOM, or majority of your providers went to the NICOM?
Easy to use, I think, is the first one. So there's 4 pads, basically. You can place the pads in pre-op. They just have to kind of box the thorax in. A lot of providers, I've noticed, didn't like the Doppler as much because it's very finicky. It's very hard to keep right in the right spot. You have to like tape it to their nose and everything.
Yeah, I call it the fiddle factor there.
Right. And then, of course, if the patient doesn't already have, if they had an A-line, they go with the FlowTrack because you've got it there. But if it's not indicated for that type of surgery, then then they wouldn't place an A-line for something like this. They would just go to the bioreactants, mainly for ease of use.
All right. And do you know if they were optimizing, well, like they say, fluid optimizing or fluid maximizing?
Optimizing. So we didn't give fluid until their stroke volume stopped going up. We basically did one maneuver with a Trendelenburg or 250 cc bolus. The highest stroke volume we got is what we went with. We didn't like keep giving them bolus, bolus, bolus until they got to the maximum stroke volume. We just kind of assumed that because they were drinking and everything up to 2 hours before surgery as part of our ERAS program, that they were already kind of at a state of euvolemia at that point. So that's kind of the thought process there. Because there have been some studies that show harm when you just keep giving people fluid to maximize the stroke volume. So that was kind of our thought process.
Okay. And then were you able to compare the pressor use during this study and your previous retrospective study?
Yes, no different between the two groups. So very low volume, like every now and then someone might get a push of phenylephrine or two, like during the case, but total norepinephrine equivalents between the two groups or by patient were no different. So yes, it's hidden in one of the tables.
Okay. And then for the second and third presenters there, are you going to be able to put in anything for smoking, obesity, and ETOH use in your studies?
Yes, those are all compared as part of this part of our demographics. We did compare that, and we did not find a significant difference between those, and that's also part of the ECOG.
Okay, good.
Any other questions? Okay, I think we're 30 seconds away from 5 minutes, so why don't we thank our presenters one more time.
We'll have the next three presenters come up to the stage.
All right. Thank you guys very much for giving me a chance to briefly describe some studies I've been working on looking at the impact of ERAS protocols and early nutrition on outcomes such as length of stay at a multidisciplinary ERAS institution. So for disclosures, this study was funded by our partners at Abbott Nutrition. So a little bit of background, ERAS protocols certainly emphasize nutrition for optimal patient recovery, and this really occurs all along that whole perioperative course, right? So preoperatively, we're talking about oral carbohydrate loading, oral nutritional supplements. Postoperatively, early immunonutrition, early resumption of oral intake. And we know that perioperative nutrition is a significant predictor of postoperative outcomes, and this is shown in a variety of systematic reviews, showing reductions in total complications, reductions in mortality, and reductions in length of stay. So the aim of this study was to evaluate the impact of ERAS protocols, including postoperative nutrition, on length of stay and compliance across 5 surgical procedures at a high-volume single-center institution. So we performed retrospective data analysis from the ERAS Interactive Audit System, the EIAS, which is the official data registry for the ERAS Society. And you can see our sample sizes there below for the 5 different surgical procedures. We then case matched that data based on age, BMI, diabetes status, sex, and surgical procedure. And then we perform 2 different types of analyses. One is your kind of standard pre-post implementation analysis, and there we're looking at length of stay and compliance to nutrition-related ERAS items, such as oral carbohydrate loading. The second analysis was a regression analysis where we regressed length of stay on early nutrition, late nutrition, and no nutrition. And so what we did here was categorize whether nutrition was delivered postoperatively, either day of surgery or postoperative day 1, and that would be early nutrition. Late nutrition would be postoperative day 2 or 3. And then, of course, no nutrition is having no postoperative nutrition, and we did exclude the non-applicable patients for that. So for that pre-post analysis, that pre and post ERAS implementation analysis, we did see significant reductions in length of stay. And so for all procedures on aggregate, reduction of length of stay from 10 to 8.3 days, and significant also for distal pancreatectomy, head and neck procedure, and for the Whipple procedure as well. We also did see numerical reductions in length of stay in hepatectomy and cystectomy. And of course, to be expected, compliance to oral oral carbohydrate loading was significantly increased across all procedures after implementation of ERAS. So for the regression analysis, which is based upon the EIS variable of postoperative oral nutritional supplements or SIP feeds given, we did see that early postoperative nutrition was associated with a 3.75-day shorter length of stay. So for patients that received that early nutrition or patients that were in that early nutrition category were expected to have a reduction of 3.75 days length of stay. And those that did not receive any nutrition, that was associated with a 3.29-day longer length of stay. So in conclusion, implementation of ERAS protocols significantly reduced length of stay in 3 out of 5 of the surgical procedures that we studied. Early delivery of post-op oral nutrition significantly decreases length of stay, whereas no post-operative nutrition significantly increases length of stay. And so really adherence to ERAS protocols and specifically to perioperative nutritional support does help to improve outcomes. Thank you.
All right, thank you very much for the opportunity to present our work entitled Preoperative Immunonutrition and Complications After Elective Colorectal Surgery. This is a 2-year prospective study. As we, choose this, how about, nope. Green button. Nope, nothing on the green button. How about the mouse? Nothing on the mouse. There we go. As we just heard, nutritional status is directly proportional to perioperative outcomes. Unfortunately, as we know, there's not a standardized screening approach for malnutrition, nor are there any obvious cutoffs to clearly define the malnourished, and there's no universal strategy on how to reverse malnutrition when encountered. For many years, the concept of enhancing the immune system through specific supplementation of amino acids, such as arginine, which is depleted during surgical stress, have been touted to improve the body's natural ability to handle surgery, and in turn, hopefully, decrease the risk of complications, mainly infectious ones. In 2012, a Cochrane review of 7 randomized controlled trials of preoperative immunoenhancing and nutrition in the setting of GI surgery found a significant risk reduction in overall postoperative complications. When a review of 83 different randomized controlled trials was done in 2017, it also showed a decrease in overall complications, infectious complications, and a reduced length of stay. However, when industry-sponsored trials were excluded, interestingly, no longer were there any beneficial effects found. In this background, we decided to conduct a prospective intervention amongst all elective major abdominal colorectal surgeries. Overnight or smaller surgeries were excluded. With the help of our institution, each patient was given a case of 15 drinks of Ensure Immunonutrition Shake to take on the 5 days prior to surgery. There were no other changes made to our ERAS protocols. Our primary outcome was a composite of overall complications. Secondary outcomes were infectious complications, specifically surgical site infections. We also looked at the length of stay. Our comparison group was a cohort of 3 years of the cases prior, also in the setting of the same ERAS protocols. Our sample size calculations were based on our historical controls showed an overall complication rate of about 28.5%. We aimed to capture about a 25% reduction down to 21.5%. In terms of our subgroup analyses, we wanted to evaluate whether immunonutrition had a greater effect on the already malnourished cohort, as identified via the prognostic nutritional index, which is mainly involved the serum albumin level and the total lymphocyte count. Due to the partly retrospective nature of the cohort, we did have to exclude about 290 cases from our historical controls to meet our criteria. It should be noted because our sample size was based on 584 in each arm. We couldn't go back further because of the changes in the ERAS protocols to the addition of universally giving people TAP blocks beforehand. Therefore, our retrospective cohort was 312 cases and our prospective was 534. In terms of patient demographics, despite attempting to compare the same set of surgeries and patients, when we looked at administrative coded trials and comorbidities, we found that the prospective group actually had fewer number of attached comorbidities. However, the ASA classification was similar between groups, and likewise, the use of laparoscopy was similar. In terms of our primary outcome, there was no statistical difference in overall complications between the groups. Likewise, the rate of specific higher grade complications and infectious complications were not different. Although, again, it should be noted the study was not powered to look at any of these secondary outcomes. Interestingly, there was a significant decrease in length of stay in the prospective cohort. In terms of the subgroup analysis based on nutritional status, in the first line, I will point out that the overall complication rates were different based on nutritional status of the entire cohort. Those with a PNI of less than 33 were twice as likely to have infectious or any complications as opposed to those who were greater than 38. However, overall SSI rates were not different between the groups. In the second and third row, you'll see here that when divided into prospective and retrospective immunonutrition cohorts, surgical site infections and complication rates were not different. So similar to other studies, we found that only the use of laparoscopy and ASA classifications were associated with a significant decrease in overall complications, while worsening nutritional status increased the odds of complications. In terms of limitations of the study, we found that there were small numbers of the infectious complications in the elective colorectal surgery cohorts. There was also, depending on administrative coding, there's changes that happen over time based on various practices. And it also should be noted that the use of ERAS over time at a certain institution improves outcomes, just as the culture changes and adherence improves. We suspect this is a significant factor why our length of stay decreased in the prospective cohort. But in conclusion, pragmatic addition of immunonutrition prior to elective colorectal surgery and an established ERAS protocol did not alter our overall complication rates. While we are not aware of any other prospective studies using this particular product, it may be worth noting it's probably not worth parsing out individual components of an ERAS protocol and trying to figure out which is the most important. And we also, by limiting our subset to elective colorectal surgery patients, perhaps we miss the more malnourished inpatient acute cases. I'd like to thank the Ferguson Foundation for Digestive Disease and my co-authors, as well as the organizers for letting me present. Thank you very much.
Good afternoon. My name is Annabelle Beck. I am a plastic surgery resident at Virginia Commonwealth University. Thank you so much for this opportunity to present our research on effective ERAS on racial disparities in prescribing practices for autologous breast reconstruction. So all authors have no conflicts of interest to disclose. So briefly on a background, racial disparities in medical practices, including our surgical disciplines, are increasingly being documented within our health literature. ERAS pathways have been introduced to reduce variations in perioperative surgical care, as well as taking it a step forward, helping to ameliorate racial disparities. The objective of our study was to assess whether racial disparity exists at our institution's opioid prescribing practices in autologous breast reconstruction, pre-ERAS and post-ERAS implementation. So we did a retrospective review of 163 consecutive patients who underwent autologous breast reconstruction from October of 2014 to June of 2021. Patients were categorized according to their timing of their surgery of being pre or post ERAS implementation, as well as according to their self-reported race as documented in the EMR. Intravenous or IV and oral or PO opioid medications were then converted to mean morphine milligram equivalents, or MMEs, to calculate for each patient their inpatient IV, inpatient PO, and total inpatient MMEs. We also collected demographic, procedural, and surgical outcome data, and we did t-tests for our statistical analysis. So this is our ERAS pain protocol for breast surgery. In the pre-op setting, all patients with allergies taken into consideration receive multimodal pain medications of acetaminophen, NSAIDs, and gabapentin. In the intra-op and post-anesthesia care unit setting, this is the only time where patients receive IV opiates, and this is anesthesia-driven. In the postoperative setting, we continue the multimodal pain medication on a scheduled basis of Tylenol or acetaminophen, NSAIDs, and gabapentin. And we also provide PO opiates on a PRN basis for severe pain only. So for our results, again, we had 163 patients. In our pre-ERAS group, we had 69 patients. Post-ERAS group comprised of 94 patients. You can see on the chart to your right the breakdown of the various races that patients reported themselves as. In dark blue, you can see these represent our patients who identified as other, which included Hispanics and Asians, and due to their small number, they were excluded from our analysis. You can see white patients comprise the majority of our groups. So when looking at our black and white patients and comparing their inpatient opiate consumption, our pre-ERAS group had a significant difference between black and white patients, black being given more IV opiates compared to their white counterparts. When we look at oral MME intake, there is no significant difference between the two races. When we look at our post-ERAS group, we do continue to see a racial disparity with black patients continuing to have more IV opiates compared to white patients. And interestingly enough, we also see a difference in PO narcotic administration with black patients, again, receiving more PO opiates compared to white patients. This is our p-values comparing the two groups of pre and post-ERAS, and you can see that overall we have significantly reduced our total narcotic administration for both inpatient IV and PO administration, with about 10-fold decrease in intravenous administration, and then about 2.5 to 3-fold decrease for oral narcotic administration. So in conclusion, racial disparity was present pre-ERAS implementation in total inpatient IV narcotic administration, and this continued in our post-ERAS implementation group. At our institution, there are currently no guidelines specifying how intraoperative narcotics should be administered by anesthesia. And in post-ERAS implementation, new racial disparity was noted in total inpatient PO narcotic administration. So ERAS implementation in our autologous post-mastectomy reconstruction patients significantly reduced overall narcotic use. However, we do need to have further study to our ERAS protocol to address the racial disparity that we are seeing. This could include for next steps discussing with anesthesia regarding our intraoperative IV narcotic protocol development, as well as discussion and education with nursing staff in the post-operative setting regarding oral narcotic administration. So thank you so much for this time. You can email any of these email addresses with any questions, and I look forward to receiving that Tesla.
All right, thank you. Thank you for 3 very good presentations. Are there any questions for these presenters?
Hi, this is for the Ensure. I forgot your name, doctor. But did you see any differences from your pre and post supplementation cohorts about sugar level, glucose levels, and any differences in your prescription of not taking any glucose, insulin or half the insulin beforehand? Because I know it's got, 45 grams of carbohydrates in there. I didn't know if that did anything to your glucose levels preoperatively.
This was done in addition to using a carbohydrate loading beforehand. So in our non-diabetic patients, they still get carbohydrate loaded. This would be just for those 5 days beforehand. So no, there wouldn't have been any. We did look at those levels. There was not any difference because they weren't taking that up for the 24 hours before. They were just doing their carbohydrate loading.
Okay, so there was no difference in terms of your preoperative orders up to half or DC, the insulin levels for them? Insulin use?
No, not based on those, yeah.
Okay. And then Dr. Beck, was there any discussion with the anesthesiologist of using any kind of blocks, neurological blocks, like PEC blocks or anything like that?
So we have looked at some data after we came with this abstract on looking at liposomal bupivacaine.
No, that's been proven to not work. So I'm talking about PEC blocks itself, which is regional blocks for your patients. Instead of using IV, any kind of opioids, using perioperative blocks. I think that would be worth discussing with them.
So my question on the disparity talk, these are patient-reported pain scores, and they're given doses based on PRN, which means they're asking for the medication. So is there anything that you guys have looked at further as far as why? Because of the scores, or is it because patients are asking for it more frequently? Are they having to be dosed higher doses to be able to get the same response?
So for our PRN medications, it's always a 5 milligram oxycodone to address the severe pain that they're having on top of it. When we compared between the races of their pain scores, there was no significant difference between their average pain score reporting. So, I mean, several hypotheses that I have is, as Dr. Coombs was alluding to about the woke culture, Richmond is a very diverse city, so are we too woke? And we're just trying to combat what we see is, Black patients aren't receiving enough pain medication. Their pain is treated poorly. So are we too woke that we're going a little bit too much of the opposite direction? And then the other part would be, are patients just, trying to refuse controlling with multimodal first and then taking the opiates, or are they just trying to ask for everything altogether?
I'd like to congratulate you on prescribing the NSAIDs and the gabapentin and the Tylenol ahead of time. How far ahead of time are you dosing those?
So in the pre-op setting, as soon as the patient comes in and they get registered, our residents are on it.
So it's like one dose immediately before?
Correct.
All right, a couple quick questions. Allison, I don't have any questions for you, but it's always nice to see you. For Dr. Beck, I would have interpreted your data a little bit differently. Have you thought about doing a difference in differences analysis? Because it actually looks like that both patients had a 90% reduction in opioids, and so I would say that you eliminated disparities in the sense of both patients had similar reductions.
That will be a really good thing to go further in. For sure.
Okay, and then for the second speaker on the immunonutrition, did you do a subgroup as far as patients with cancer versus those without cancer? And was there any difference there?
No, we did not break down in terms of disease process. It just further make our numbers smaller. But just by breakdown, it didn't show all that. It was about 30% of these are cancer, and then about 30% were IBD, and then the rest being benign, like diverticular disease.
Okay, might be interesting to look at that, because I think the data that I've seen has tended to be more stronger in the cancer-specific population as far as, but I don't know if that bears out in yours or not.
I'm not totally convinced, just because oftentimes they're not multi-organ resections, but more just straightforward colectomies.
Got it, thanks.
Hi, for Dr. Beck, as far as the racial disparities are concerned, with your pre-ERAS, was there any type of anxiety scoring or to figure out what these patients' anxiety levels were, white versus black, before your ERAS protocol? And also any pre-existing notions about pain and any preoperative education?
We have not done any of those things. We didn't look at anxiety or just talking to them about ahead of time, what to expect. But that is something we're looking into, of definitely discussing with patients who are to expect to have pain. You're never going to be at 100% zero. So that's something we're definitely looking into.
Thank you.
All right, thank you to our presenters and our questioners, too. Okay, we'll have our last group of presenters come up.
I believe I have two.
Oh, you have two?
Okay.
You do.
Okay. Good evening, everyone. My name is Meshka Anderson. I'm a general surgery resident at Carolinas Medical Center in Charlotte. So thanks for the opportunity to present one of our first abstracts that deals with the additive effects of robotics and ERAS pathways in patients receiving major hepatobiliary operations. So one question that frequently comes up is that, does MIS obviate the need for ERAS given the similar benefits that both provide? So there have been multiple small studies dealing with these questions, and the data trends tend to suggest that there is an additive effect versus them of one obviating the other. So currently there's no level 1 evidence suggesting this additive effect, but the closest we've come is the Orange study that was done in the Netherlands back in 2017, and the attempt was within an ERAS program to randomize patients to either an open left lateral hepatectomy versus a laparoscopic component. Their data did not show any difference in their end outcomes, such as length of stay, readmissions, or mortality, and this study was actually stopped prematurely due to slow patient accrual. So our aim with this abstract was to look at the effects of robotics and an ERAS protocol when patients receive hepatectomies. So we have a prospective database of patients that we looked at from 2008 to 2020, and we looked at our robotic cases. Our outcomes of interest were the compliance with the ERAS pathway, length of stay, and postoperative complications. So we ended up with a total of 252 robotic hepatectomies over this study period. We had a pre-ERAS group that was 79 patients and a post-ERAS implementation group that was 173. We looked at our results based on patients who received major hepatectomies, which is more than 3 segment resections, and those receiving minor hepatectomies. So from the major hepatectomy group, in terms of the outcomes, the statistically different outcomes included an increase in the readmission rate in the post-ERAS implementation and an actual decrease in our Clavien 3 and 4 complication rate post-ERAS implementation. In terms of our compliance, the only statistically different outcome was not replacing or keeping the NG tube out, after extubation. In a minor hepatectomy group, there were no difference in the outcomes listed here, pre-ERAS implementation and post-ERAS implementation. And in terms of our compliance, the statistically different results were an increase in the reinsertion of the NG tube post-ERAS implementation and an improvement in the early post-op day 0 ambulation rate post-ERAS implementation. I wanted to make note here of, and I should have did that for the major group, So in the major hepatectomy group, you can see PRN doses, both patients use opioids in both groups, but in the major hepatectomy group, there was a 33% reduction in the opioid use post-ERAS implementation. And similarly for the minor hepatectomy group, both patients used PRN opioids, but there was a 10% reduction post-ERAS implementation. So summarizing the synthesis effects of robotics and adding an ERAS protocol, in terms of statistically different outcomes, in the major hepatectomy group, we did see an increase in the readmission rate from the major hepatectomy group, and this was due to mostly pain control. So while we were fine-tuning what protocols we used, we had an increase during that period of time. We did see a decrease in our complication rate in the major hepatectomy group with no statistical difference in the other measures. In terms of compliance, we did see an increase in the reinsertion rate for the NG tube in the minor hepatectomy group, and this was the one part where I can't quite have a rationale for it, but that's what the results showed. And then a synergistic effect with not using the drain and not reinserting the NG tube, early ambulation, and decreased opioid use in terms of protocol compliance post-ERAS implementation. So in conclusion, with our minimally invasive surgery and ERAS protocol, we've seen a benefit in terms of our decreased length of stay, post-op pain, and morbidity. The data trends are suggesting a synergistic effect between minimally invasive surgery and our ERAS protocols. We do not have level 1 evidence as yet to support this synergistic effect. We have a statistical decrease, a statistically significant decrease in our complication rates, and a measurable statistical increase in early mobilization and decreased opioid use. Thank you.
Hi, I'm Catherine LaRusso. I'm presenting on behalf of the Pediatric Colorectal ERAS group. I'm a PGY4 general surgery resident at Georgetown University Washington Hospital Center in Washington, D.C. But this research was initiated at McGill. Use of enhanced recovery principles have been associated with improved outcomes in adults and are increasingly being used in pediatric surgery, yet few pediatric guidelines exist. A systematic review in 2015 showed only 5 articles, for example, in pediatric colorectal surgery. Since then, more articles have been written, many of which are single-center studies, however. We sought to formulate guidelines for pediatric colorectal surgery based on the current evidence to improve outcomes and generate consensus around core principles. Using the guidelines created by the ERAS Society in 2019, we are currently following the approved process for guideline development. Using 3 rounds of a modified Delphi method, we created 17 preliminary ERAS topics to include in our guidelines and the development of our target population. Our target population is currently children 4 to 18 years of age undergoing elective colorectal procedures. We utilize the PICO format further to develop inclusion criteria for our process. 2 medical research librarians from McGill conducted comprehensive literature searches for each topic. The searches were done using databases listed here from 2010 to 2021. The main search strategy used keywords for each topic, plus relevant subject headings with respect to pediatric colorectal surgery, combined with enhanced recovery terms. If evidence was specific to colorectal surgery in pediatric patients was lacking, which in most cases it was, the search strategy was expanded to include indirect evidence from adults and other pediatric studies. Here's a list of the current topics we've included using the ERAS Society format. About 9,000 references have been screened on the following topics. Each reviewer has currently completed their specific systematic review, and we are now in the process of determining, as a group, the evidence to include in the development of the guidelines. The quality of the evidence is being assessed using the grade system, as well as for the strength of our recommendations that we will develop. In general, the evidence for most topics is heterogeneous and indirect. However, there is new data which is encouraging. The strength of the evidence is overall low to moderate and mostly focused on adults, like previously mentioned. Each member has currently finished their initial review of the evidence, and we are now starting the peer review process where we can generate consensus around the evidence in which to include. And also, when we develop the strength of recommendations, we're going to be looking at both the potential benefits and harms of those recommendations. We'll then plan to finalize and disseminate the guidelines within the next year. We hope the guidelines will help to reduce trauma, stress, and inflammation in pediatric surgery, and really ultimately hope to improve surgical outcomes, as well as to encourage centers to develop prospective studies around specific recommendations to add to the growing literature in pediatrics, which is much needed, such that children can also benefit from ERAS principles similar to adults. Thank you for all the members of our pediatric ERAS team for their valued contribution to this process. Thanks very much.
All right, thank you again, guys. So this second abstract is looking at ERAS pathways in octogenarians undergoing major hepatobiliary surgery. So within the hepatobiliary space, we've had a reduction in our postoperative length of stay that has been primarily been attributed to implementing ERAS pathways within our hospital. So despite these benefits, it's not quite clear if these protocols would be best suited for patients who are greater than 80 years old, just based on us seeing older patients more frequently in our clinics. But we do know the benefits of perioperative optimizations, especially in reducing frailty in these patients to aid with their postoperative recovery. So the aim of our investigation is to assess the impact on ERAS protocols in patients above 80 years old in a prospectively maintained database of octogenarians undergoing major hepatobiliary surgery. So this data, again, was collected from 2015, 2018. Our major hepatobiliary operations were defined as pancreatic duodenectomies, distal pancreatectomies, and hepatectomies. We looked at post-op length of stay, 30-day major complications, readmissions, and mortality. So we obtained in a pre-ERAS implementation group about 8 patients who were above 80 years old, and then post-ERAS implementation, we obtained about 27 of those patients. This table is essentially looking at the ERAS compliance, so them staying within those protocols, and we've seen essentially a statistically significant improvement in keeping or maintaining those protocols post-ERAS implementation. The second table looks at those outcomes. So the only statistically significant outcome that we saw was in the 30-day readmission rate, which we saw a decline. Things in terms of length of stay, 30-day major complications, and 30-day mortality, there was no difference in the pre-ERAS implementation group versus post-ERAS implementation group for patients over 80 years old. So some questions that may pop up when you're evaluating somebody over 80 years old who may need a major hepatobiliary operation is, should surgery be offered in those cases, or, what's the expected life expectancy in somebody over 80 years old? So looking at data trends over the past 50 years, so there's been about a 10-year increase in the average life expectancy for patients in the US. Back in the late 80s, there was one study that looked specifically at patients at 80 years old and see what their life expectancy was. Now, I see there's just one demographic that was represented here, but at 80 years old, males were expected to live an additional 7 years, and females were expected to live an additional 9 years, and that was at year 80, and that was in the late 80s. And so just general data on the survival rate on these major diagnoses that may require an operation. In terms of pancreatic adenocarcinoma, we see the 5-year survival rate anywhere between 10 and 25% over the past 10 years, which back in the mid-80s, that number was about 3%. In terms of resecting colorectal metastatic disease, 5-year survival rate is about 30%. In terms of localized HCC, 5-year survival is around 30%. So we are seeing an improvement in the 5-year survival rate in treating these disorders or these diagnoses. So following the implementation of ERAS protocols in our patients above 80 years old, we saw a significant decline in our readmission rate. We saw a stability in the length of stay. We saw them maintaining their compliance with the ERAS protocols about 64% of the time. There was no change in the 30-day major complication or mortality after implementing our ERAS protocols. And so in the setting of an increasing life expectancy with similar outcomes, we concluded that major hepatobiliary surgery is justifiable in patients above 80 years old, especially when you're doing this in the setting of a ERAS pathway. Thank you.
Are there any questions for our presenters?
First is for Dr. Anderson. First of all, congratulations on your studies. So you clearly showed benefit from robotic and MIS to open surgery. As an MIS surgeon and someone just starting to use a robot, one of my bigger questions would be checking the benefits between MIS laparoscopic approach versus robotic, because as more and more folks are doing major operations as you're doing, I mean, that's an impressive number of robotic hepatectomies, but seems like as we move into the MIS space and people are using the robot more and laparoscopic surgery more, looking at the comparison between laparoscopic surgery versus robotic surgery. Did you happen to think about that, or?
We are starting to collect that data, but I don't have finalized answers yet. But yes, we are definitely starting to look at comparing laparoscopic operations to robotic operations.
So in our institution, we're doing both laparoscopic hepatectomies and laparoscopic and robotic hepatectomies, major and minor. We have about 650 cases total, minimal invasive, about 300 there, the robotic, and 350 there, the laparoscopic ones. Whipples-wise, we're doing them only robotic. We don't do laparoscopic whipples. We have about 250 whipples. And distal pangs, we do them both laparoscopic and robotically. I can tell you that as long as you do them in a minimal invasive manner, it doesn't matter which way you do it, robotic or laparoscopic. What is the difference between the laparoscope and the robot, at least to our experience, is the following. Whipple is a very demanding procedure, and it has a lot of reconstruction. And you need to have a certain chip in your brain to be able to do it laparoscopically. There are about 10 people in US that can actually do it. And the reality is that when you see them, you see that some of them, they don't do it well. Maybe 2 or 3, they are doing it very well. Robot, on the other hand, is a potentiator. It can make an open surgeon become a minimal invasive surgeon. We have done some studies, survey, it's qualitative analysis between HPB surgeons, and we can see that 3 out of 10 open Whipple surgeons, they can convert to MIS because of the robot. So I would say that this is the benefit of the robot. It makes more people do minimal invasive surgery. I'm not quite sure this is going to be the same thing for colorectal, because for colorectal, there are very many skilled colorectal surgeons in laparoscopy. So I'm not quite sure if the robotic platform is going to offer something more. Am I answering your question?
Yeah, it's fantastic. That's great. Yeah, no, I love that. That's exactly sort of where I was headed. And then as a pediatric surgeon, Dr. LoRusso, excited to see that we're finally starting to get some guidelines for pediatric ERAS that we can start to follow. So excited to see the work you're doing. Our team at Vanderbilt would be excited to collaborate with you as you develop these guidelines and as you proceed forward with prospective implementation of these guidelines. So congratulations.
Great, thank you very much.
Yeah, my question is for Dr. LoRusso. Also agree it's going to be great to have these guidelines come out so I can share them with our pediatric colorectal colleagues. My question is, are the guidelines meant to apply broadly to the specialty, or are they condition or surgery specific, or are there exclusion criteria?
Sure, thanks. So it's a great question. It's kind of a little difficult. So we decided to just sort of keep it broad as elective colorectal surgeries, including and not looking just only at inflammatory bowel disease, so for Crohn's, strictures, or total colectomies or something. So we're also including stoma takedowns, reversals, and stoma creations. And we also decided to also include sort of like broadly, and potentially we'll make some subset recommendations for the unique category of Hirschsprung's disease and pull-throughs, as well as PSARPs potentially for ARMs. And so we're going to have to see how that kind of develops as the guidelines are made. But I do think that there is general guideline principles that are in adults that can be translatable to peds. And it's just formulating like what evidence is really out there and what kind of guidelines can we make based on the quality of the evidence and the recommendations that are safe for children.
Thanks very much. Liz Everett from New York. My question is for Dr. Anderson. In the second study that you presented, part of your conclusions were that there was a reduction in readmissions. Sorry, there was a reduction in readmissions in the post-ERAS group, yes, but there was no difference in complications at the same time period. That seems a little incongruent. I wonder if you could comment on that.
So looking at again, this is probably skewed by the sample size, but essentially we were looking at, over this 30-day period, how many of those patients got readmitted, and I believe it's the same issue that I presented with the initial paper, where it was mostly pain control. So there necessarily weren't any major complications in terms of Clavian 3, 4 requiring us to go back to the OR, but it was more them coming back for inadequate pain control.
Dr. Anderson, your second presentation, did you see a difference, or did you look at whether patients went home versus to a skilled nursing facility, and whether there's a difference before and after ERAS?
I actually don't have that information, sir, if they went home or to a skilled facility.
And out of curiosity, your first talk, duration of the surgery, was it the same before ERAS and after? Because I guess especially with the robot, there's some learning curve, and people have gotten a lot faster. Duration of surgery might have an impact.
So in terms of the specific numbers, we didn't gather the length of the operating room, but the surgeons have been the same over that period of time, and they've been using it for several years. So my assumption is that those numbers are going to be about the same.
And the other question would be, does it matter whether it's right versus left major hepatectomy in terms of your reinsertion rate for nasogastric tubes?
Not that we could discern from the data, sir.
I was just going to make a quick comment as well on following up on we just published first author Dan Rubin from the University of Chicago on the trends in surgery across the US on elective colorectal on age groups. We found that survival is better, but in the over 80s, although more are surviving, less are going home. So they're going, and not surprisingly, but I do think from our ERAS work, that's something that we have to think about. So,
Okay.
Congratulations on that, both great talks.
Thank you.
For Matthias' questions, let's start with the learning curve. If I remember well, the data that you presented is from 15 to 18, correct? So this is far away from our learning curve. We started doing robotic hepatectomies in 2012, so we do not have learning curve factor there. The second question was about readmission rate. Why is it smaller while lower while the length of stay is the same? A very simple answer would be the type 2 error, very small sample size. In fact, we have right now about 60 octogenarians in our registry, and we still see the same finding. I think what has happened since 2019, and that can explain, it has nothing to do with ERAS, it's the fact that we started doing virtual visits. So we see the patients more often when they are at home, and we pacify them, we put them at their heads at actually should go for the families, not for the patients. But they feel easier and they feel better. That's why they do not come to the hospital. The other thing that we have implemented since 2017 is a patient-reported outcomes platform. We are using a proprietary software. We're not like Kevin, that he has developed his own. And we have found out that they decrease readmission. In fact, this is the element that has helped us decrease readmission rates. So there are other confounding factors that can explain the decreased readmission rate. It's not, I don't think that it has to do anything with ERAS, to tell you the truth.
All right, thank you once again to our presenters and our questioners. If the presenters haven't already done this, please see Dr. Scott to let him know which model you'd like and which color. Thank you.
Ladies and gentlemen, I think that concludes the academic portion of the first day of this Congress, and I hope you can join us for an informal welcome session just outside. And tomorrow morning at 7 a.m. An educational breakfast before the day starts at 8 with the breakout sessions for peds and spine. Thank you very much again for being here, and looking forward to having more exciting discussions. Thank you.